Um, so there are different thresholds at which you decide whether to transfuse or not to transfuse. It varies based on one, the gestational age, and then also how old the baby is postnatally, and then also whether the child is stable or unstable. So you have a 10 baby whose HB within the first week is 10 grams, as against a baby who, another 10 baby, HB is 12, but has neonatal sepsis and is very ill. The 10 baby who has a 10 gram per deciliter in the first week would be considered anemic and will need a transfusion. The one who also is having 12 gram per deciliter, but is acutely ill with neonatal sepsis, may still require transfusion. So these are just guidelines. The thresholds displayed here are just guidelines, and you still need your clinical acumen to decide on when to transfuse. But I'm sharing this so that we know, at least we have a guide to when we need to transfuse and at what threshold we should consider transfusing. Yeah. Again, I talked about different processes that red cells can be taken through. So you can either have washed red cells, you can have leukoreduced red cells, irradiated red cells, and then CMV negative red cells. Now, these blood products are important because in certain situations, you may require these specialized red cells. In most NICUs outside Ghana, at least, they prefer to use the CMV negative red cells so that there's no risk of transmission of cytomegalovirus disease to the baby from transfusion. Again, they also tend to use irradiated red cells. So and there are no white blood cells in the donor blood that they are given, which sometimes can, if the recipient is immunosuppressed, the donor white cells can actually attack the recipient patient. So these are specialized processes that blood is taken through just to reduce the incidence of infections and then also transfusion reactions, especially graft versus host disease. In Kolebu, at least the National Blood Bank Service is close by. So when we do require, we've been able to get washed RBCs when we needed to. So we had one patient that after transfusing, we realized that the HB rise was not, actually the hemoglobin level went further down than the pre-transfusion HB. And so we needed to top up the blood. So we requested for washed RBCs and we were able to get that from the blood bank. But these are not routine blood products that you find in most blood banks. But you can ask you can have a conversation with your blood banks and see what is possible, but most of these are actually not available. Now let's talk about fresh frozen plasma. So this is a plasma component of blood. It is usually, so plasma contains the clotting factors, immunoglobulins, and so if you have a patient who is actively bleeding, patient with liver disease, because liver is what produces most of the clotting factors. Then or a patient with DIC, you can use FFPs. I mentioned earlier that now most people are moving towards using reconstituted red blood cells. So they use packed red cells with FFPs to do exchange transfusion rather than taking whole blood to do exchange transfusion for severe neonatal jaundice. So for FFPs, you can consider them in these scenarios. Now, when you take FFPs from the lab, once you thaw it, you can't refreeze it. You've got to use it. So remember that blood is not so available as we would want it. So when you do take the product, you have to have your clear indications. If you're not going to use it, then you might as well not hold it in the blood bank till you are ready to use it. Because once you thaw the FFPs, you can't reuse it. You can't refreeze it to store. Again, when you're thawing it, you can ask the blood bank to thaw it for you. They have specialized warmers that they can use. But if you take it frozen from the blood bank, then you put it in water to thaw it. You should make sure that there are no cracks or tears on the plastic. If not, if you see any leakage, you should return it to the blood bank. You can't use it. And then she also examined the bag to make sure that there are no blood clots in the bag. Ideally, if we had the services, then it should also have it should also be leuko-reduced, meaning that any white cells should be taken out, but we don't have that service also in our setting. Platelets can also be prepared from whole blood, and usually platelets concentrates do not last very long. They are prepared from fresh blood, and it lasts for just 5 to 7 days. It has a 5 to 7 days shelf life. So we use platelet transfusion when we have babies with thrombocytopenia with active bleeding. Normal platelets, we count from 150 to 400 times 10 to the power 9 per liter. But if you have thrombocytopenia and the baby is stable, you have to get to a level of about 20 before you consider doing a platelet transfusion. However, if the baby is less than 28 weeks or the birth weight was less than 1,000 and the baby is not active bleeding, then use a threshold of 50. If the baby has thrombocytopenia and is ill, so is having apnea, is lethargic, is in respiratory distress, then for that, you use a cutoff of 50 to decide on platelet transfusion. If the baby requires surgery or has major bleeding, then you need, sorry about that, you need a level of 100 times 10 to the power 9 per liter of platelets to decide on transfusion. So if the child has, so is going for a major surgery and the platelet is 50, you'd have to build up the platelet to at least 100 before the baby goes for that surgery. Cryoprecipitate is prepared from plasma and has more of factor 8 deficient, factor 8 clotting factor. So we use it mostly for babies that we are suspecting factor 8 deficiency, the hemophilia. So let's say a baby comes in, you're thinking there's a history of circumcision, baby is bleeding from the circumcision site. There's a maternal history where she has other male children that have had uh, uh, hemophilia, or she has or bleeding post-circumcision, prolonged bleeding post-circumcision, or has uncles, maternal uncles who also have such history, then you may not have been able to do a factor assay, but you can, if you have in your blood bank cryoprecipitate, you could use that to show up the factor 8 level so that the bleeding can stop. If you don't have, then you can use FFPs. So let's say you decided that, okay, this baby has uh, anemia. You want to use heart cells, or this baby has subgaleal hematoma. The head size is increasing. You want to do whole blood, or this child has the baby has thrombocytopenia. You've decided on your indication. The baby needs platelet transfusion. How much should you transfuse? So if it's whole blood, we usually use 20 to 30 ml per kg of whole blood. If it's concentrated red cell, we use 10 to 20 ml per kg. That's a volume you request from the blood bank. If it's FFPs, 10 to 15 ml per kg. If it's platelets, 10 to 20 ml per kg. If it's cryo, 1 unit per every 5 kg of the baby. So then for our unit, we'll always probably just get 1 unit of cryo. Now, how fast should that blood product run? If you are using whole blood, one, that blood that you're taking from the blood bank you should finish your transfusion within 2 to 4 hours. Anything more than that makes the blood unsafe to use for that baby. And then you should start your transfusion within 30 minutes of getting the blood from the blood bank. So sometimes we have this habit of taking the blood from the blood bank, then we come and put it in our ward fridge. The fridge we are storing maybe medications and other things. So that ward fridge is not a blood, it's not purpose for blood storage. So you can't count that as the blood being in a fridge. And so you count your hours from the time you take the blood product from the blood bank fridge. Once the blood is out of that fridge, you should be ready to start your transfusion and complete it within 2 to 4 hours if it's whole blood. If it's whole blood, you should start your transfusion within 30 minutes, and then you should run it at 2.5 ml per kg per hour. If it's CRC, same thing as the whole blood. If it's FFPs usually will run faster. You should have been able to complete that transfusion within an hour. If it's platelets, within 30 minutes, you should have transfused it. If it's cryo, also within 30 minutes of thawing it. Yeah. ABO compatibility. So our babies, so normally, if let's say you're transfusing an older child or an adult, all you do is take blood sample from the patient, you send it to the blood bank, then they do the grouping for the patient, and then they do a cross-matching with the donor blood to check for compatibility, and then you do your transfusion. But for newborns and infants up to the age of 4 months, they tend to have maternal antibodies in their blood. And these antibodies may also may react with the blood products that you transfuse. So if you're going to do a transfusion for a newborn or a young infant up to the age of 4 months, it's ideal that you take both mother and baby's blood to the blood bank so that they do the grouping for the baby and then do the cross-matching against both mother and baby before that blood is transfused. If for some reason it's an emergency and they can't do the grouping and cross-matching, at least they can use an O negative blood, but still cross-match against mother and baby before the blood is transfused. So if you are doing red cell transfusion, let's say whole blood or red packed red cells, you have to make sure that the blood is ABO compatible and then resource compatible. So if the baby is O positive, your first choice of blood is O blood. An O positive baby can take O positive or O negative. An A baby, his first choice, he can take both O or A blood. But if you have the choice, then if both A and O blood is available, then you should go for the A blood as first choice, and then O if A is not available. Same for B. If patient is B, then B blood first. If that is not available, then can use an O. If it's AB, then AB first. So it's more like group compatible comes first if you're dealing with RBC transfusion. As well as you need to check RH compatibility. If it's FFPs, it should be ABO compatible. So the blood group should be compatible, but not necessarily RH compatible. Again, if you have the choice for the blood group that the patient is, that should come first as your first choice. With the platelets, you can actually use any blood group for the patient, but if you also are spoiled for choice, then you can use your first choice should be the group compatible product. Okay, but if the patient is O and there's no O group platelet, you can use any blood group. Especially if like your patient is bleeding, you go to the blood bank, there's no O platelet group. You can use any other group for the baby. Same for the cryo. It can be used without ABO compatibility. So any of the groups can be used, but if you have the choice, then you can start. Your first choice should be your the group that the patient has. So let's talk about transfusion. It's a process. It's not just you get blood, you transfuse. As we all know, there are things you do before, things you do during, and then things you do after a transfusion. So before the transfusion, you should, first of all, be clear in your mind what the indication is. Why does this person need the transfusion? Which products does he need? Are there any other alternatives? Is this blood really necessary? You need to be clear about that. And then you need to communicate among your team and then to parents. I think the next topic to be discussed is handing over. So let's say you came in the morning, a decision has been taken about blood. You may start the process, but you may not be the one setting up the blood. So you need to hand it over so that the next person knows what is happening, and so that you don't come, the team doesn't come back the next morning. It's like, oh, we didn't know about it, then the transfusion is not done. Then by the next day, the patient is more worse than we found him to be the previous day. You need to also communicate with parents about the transfusion. That's why the transfusion, the benefits, as well as the risks. A lot of times we kind of shy away from telling them about the risks, but it's important that they know about the risks involved with blood transfusion. Informed consent. So that's an interesting area. So it comes up most of the time. Parents don't refuse when clinicians tell them about blood transfusion and why it is necessary for their child. But a few times you come across parents who, because of religious affiliations or beliefs, do not want to accept blood for their babies. But always remember that in taking decisions for children, it is the best interest of the child that is upheld, even if the parents' beliefs are against it. You need to take samples for the baby as well as the mother and correctly label it to send it to the blood bank so that they can process the appropriate blood product and group for the transfusion. You need to fill a request form. Now, most places are using the LIMS, and I think the request form is now in the LIMS. Places that don't have the LIMS, the electronic system so operationalized, still use the paper form, but you need to fill a request form, whichever way, electronic or by hand, to send to the blood bank with the samples. Then the blood bank would do their processes of grouping and cross-matching. And then they would tell you that the blood is ready. You take it, and then again, you need to check on the blood product, whether it is what you requested for. Is it the blood product you requested for platelets and you have a FFPs? That's not what you requested for. What's the batch number? What's the expiry date? What is the product itself whole? Are there you have are there leakages? You've got to check all that, and then you've got to check importantly whether the product is for the patient that you are going to transfuse. So usually they would have the blood labeled with a name and identification of the patient. You need to check whether that is the patient that you're going to transfuse. And then before you start your transfusion, you're supposed to check the vitals of the patient before you set up that blood. Pre-medication. So a lot of times we really don't need pre-medication. If you have a clear indication, have selected the appropriate product. So if you have concerns that the patient be overloaded, then one, you can either decide that you transfuse smaller volumes, or you then can use diuretics, which commonly we use IV furosemide, so that you prevent fluid overload. But in most cases, so if you have packed cells, it will be best to use packed cells rather than whole blood, so then you don't have this extra volume of that can cause fluid overload in the patient. In a few cases, you may do pre-medication of steroids, but that's in very few cases that happens. Now, during the transfusion, once you set up the blood, you have to monitor your patient, because a lot of times the transfusion reactions happens in the first few minutes of setting up that blood. And it's the changes in your vitals that would sometimes alert you to what is coming. So when you set up the blood, you should have your vital monitoring at least at 0 minutes, 15 minutes, and every hour into the transfusion. And you're monitoring your patient general appearance, temperature, pulse, respiration. In the older children and adults, they'll add blood pressure. But I know we don't commonly do blood pressures in our settings and for our neonates. Then you document these vitals. So most of the time our neonates tend to take very small volumes. If you have a baby that the team thinks that will probably require subsequent transfusions, one of the things to do is to tell the blood bank to prepare the blood products into smaller volumes from the same donor so that it also reduces the risk of transfusion reactions. And most of the time when we take blood from the blood bank, they give us the given set. That given set has a filter. It is very different from the given set we use to give our IV fluids and other medications. And we need to use that blood given set because it filters the blood. So sometimes we have the situation where we draw the blood into a syringe and use a perfuser to give the blood because it's a small volume and it's going to go at a very slow pace, and setting it up with a given set is a bit challenging in how to regulate it. But if you're even going to use a perfuser, you still need to run that blood through the filter before you draw it into that syringe to use on the perfuser. So please let's remember that the filter in the blood giving set is important. After the transfusion, again, you need to monitor your patient. And it's ideal that, again, you do at the end of the transfusion, 15 minutes after the transfusion, and then 4 hours after the transfusion, you need to monitor your vitals and record. And then we also need to document all the processes that we are doing. When to check the full blood count again to see what your parameters are. If it's red cell, you can repeat it within 48 hours. If it's platelet, you can do it within 24 hours. If it's FFPs, you can do your coagulation profile to check whether your clotting profile indices have improved within 24 hours. Documentation, that's something for blood transfusion, you need to document. You need to document before, during, after, all the things that you are doing for the baby. And if you happen to have any transfusion reaction, you also need to document. Okay, I've been speaking for a while. Please, can somebody tell me whether I am being heard or I'm speaking to myself?
Doctor said we can hear you perfectly well.
Okay, thank you very much for the feedback. So I talked about documentation. So apart from the clinical notes we write about the transfusion and the vitals and writing out the batch number, expiry date, and the details of the transfusion, there are certain forms that we necessarily have to be filling. One is a consent form, the blood request form, blood transfusion monitoring form with the vitals that we are checking through the transfusion. And interestingly, in the clinical guidelines for blood transfusion, I found this other form called transfusion record form. So interestingly, after transfusing, we are supposed to fill this transfusion record form to indicate that we have transfused this blood product and whether there were any reaction or it went well. We are supposed to have this done. But I'm not sure I've seen anybody fill one yet. Please, if you have, after my presentation, you can mention if you're filling such a form, but it's one of the forms that we are supposed to be filling. If there's a transfusion reaction, again, we are supposed to fill a request for investigating that transfusion reaction with, and then send it along with a blood product to the blood bank for the processes of investigating that transfusion reaction to start. So now let's talk a bit about transfusion reaction. Be done soon. So we have a number of transfusion reactions that can occur. One is anaphylactic reaction, and that can occur within minutes, where you have angioedema. So you have swelling around the mouth, in the airway, can cause respiratory distress. Your blood pressures can drop. It can be severe. And for such, the treatment is to stop the transfusion, keep the IV line patent, give epinephrine. Sometimes you have to do vasopressors, and sometimes you even have to end up in the ICU. Allergic reaction, I think, is what we commonly see sometimes with the transfusion, where you have urticaria. It's less severe than the anaphylaxis, and for that, if you give an antihistamine, it corrects. And then you can actually even go back to continue no, you give antihistamine and then it resolves. And this allergic reaction usually occurs within an hour of the starting the transfusion, unlike the anaphylactic reaction that starts almost as soon as you start the transfusion. Then acute hemolytic transfusion reaction. So this one usually occurs within an hour, and it's usually because sometimes there are errors with the ABO incompatibility. It could start from wrong labeling of the patient's blood from the ward, or at the blood bank, or when the blood comes to the ward, we're not checking accurately whether this blood product is for this patient. It can lead to hemolysis, and it presents with fever, chills, pain in the flanks. Okay, so pain, the babies won't tell you about pain in the flanks. But you have hemoglobinuria, the urine may become dark, and then you may have DIC, bleeding from orifices, kidney injury. It can be really severe, and for that you may end up in the IC. In some cases, you have delayed transfusion reaction, where after the transfusion, everything went okay, but a day or two afterwards, sometimes up to as much as 2 weeks after the transfusion, then the you find that the child's HB, baby has been transfused, but the HB is not matching the transfusion that the child had. You're expecting an increase, but rather it is low, and that's because the patient has formed antibodies to the blood that was transfused, and that is causing the red cells to hemolyze. But you may not see any obvious signs on the patient, like the way the acute transfusion reaction happens. Then you have febrile non-hemolytic transfusion reaction, where the patient just has fever. And this one is important to recognize, because if you're doing your vitals, then you recognize it, because it's usually the fever, the rise in temperature by 1 to 2 degrees from the baseline. before you started the blood. And that's happens because there's the white cells in the donor blood you are given release cytokines, which causes this rise in temperature. And that can occur within 6 hours of the transfusion. In some cases, you can have acute lung injury that can also take you to the ICU, where the child gets severe respiratory distress. If you take an X-ray, you find that there are infiltrates almost looking like a pneumonia, which was not there before. And that's also occurs within 6 hours of the transfusion. So you probably may have finished your transfusion, but then this happens soon after the transfusion. There are other transfusion reactions. I didn't put it up here, but there's also associations with necrotizing enterocolitis. So it's been noticed from some observational studies that blood transfusion, babies who get transfused, especially the very low birth weight, those less than 1,500 grams, after transfusion, blood transfusion, a week after, or within a week, then they have necrotizing enterocolitis. That can also so something that is it the transfusion that caused it, or was it anemia that the baby had which caused hypoxia to the GIT that resulted in the transfusion, in the necrotizing enterocolitis? It's a bit unclear how that happens, but there have been cases where after transfusion, there is necrotizing enterocolitis following that transfusion. Now, are there any strategies to prevent anemia in neonates? Yes. Now, I'm sure most of you have heard about delayed cord clamping. So that has been known to reduce the requirement for blood transfusion later on as in the neonatal period. And then also good nutrition and iron supplementation. So you realize that most of our preterms, we know already that they are prone to having anemia of prematurity. So we supplement them with iron. Some institutions start as early as 2 weeks, some start 3 weeks onwards, iron supplementation, all in an effort to prevent anemia and then the need for transfusion. And then blood sampling. Our neonates tend to suffer a lot in the NICU. Today we are taking full blood count, tomorrow it's this sample and this sample, and sometimes just even setting a line for their medication. We'll try here, there, the scalp, the leg, the hand, all over the place. And every time that you're pricking here, that's all small volumes of blood that is the baby is losing. So if we can cluster the procedures we do on our patients, it would help. And then also making the logistics available, having a vein finder or having good lights to set the lines would also be helpful. Some people have talked about erythropoietin use in also in anemia. It is helpful, but it is not, you can't use that in an emergency because you need time for the erythropoietin to work. So it's in an emergency situation, we don't talk about erythropoietin. Now, myths and misconceptions. So I don't have any here. I'm hoping that you would fill me in on the myths and misconceptions, and then we can discuss it. So thank you very much for listening. And these are my references. And I'd like to acknowledge Dr. Salimenu, neonatologist at Kolebu Teaching Hospital, and then Dr. Eugene Tete. He's a hematologist also at Kolebu Teaching Hospital. So, moderator, I'm done. If there are any questions or comments, thank you.
Wow. Thank you so much, Dr. Nseidu, for sharing your valuable insights with us today. We really appreciate you sharing your knowledge with us today. Please, you can send in your questions through the chat box. But I don't know, we can take 2 or 3 questions before we move on to the second speaker. When you're ready, you can raise your hand that we mute yourself and ask the question.
Oh, okay. So I'm not seeing, okay, let's see the chat box. So if there are questions. Okay, so there's a question from Bafo. Hello. Do we
There are a
consider
few
the
questions in
weight?
the chat box.
Okay. Do we consider the weight in transfusing neonates? Yes, yes, yes. You need to. Hello. Hello. Yes. You need to consider the weight of the baby in transfusing whichever product, because the volume you would transfuse is based on the weight. Remember, neonatal, everything you're given, you have to do it by the weight. It's not like the adults that one size fits all. In neonate, you have the preterm, you have the term, you have the small for gestational age, large for gestational age. So everything is really by the weight. So I'm hoping you can see this slide. So it tells you how much volume you can use to transfuse depending on the weight, and then also depending on the blood products that you are using. Thank you. Is there another question?
Yeah, Dr. Said, I think someone would like to know, how would you know if a baby has a cardiac overload? They wanted to know the clinical presentations that would alert you that this baby has cardiac overload.
Okay, so it starts with your vitals. One is that you need to know your baseline vitals. What was the heart rate of this baby before the transfusion? And then, so if there's a rising heart rate, so tachycardia, and then also you find that the baby initially was resting calm, but now is in respiratory distress. If a doctor is around, when he listens to the chest, he can actually hear crepitations in the chest, or you're having initially the liver was not palpable, but now the liver is palpable. Those are signs that baby has become overloaded. So it starts with the heart rate and then the respiratory rate. You find that your respiratory rate is gone up. Baby now requires oxygen or is having recessions, is having increased heart rate. Those are the things that at least will start off first before the liver palpation, and then somebody listening to the chest to find crepitations in the lung bases. Yeah. Any other question?
Please, any other question? Okay.
Please, in transfusion reaction, can we continue the transfusion in some of the reactions? Okay. So most times, if you have a transfusion reaction, the first thing is to stop that transfusion. Um, the first thing is to stop that transfusion and flush the line with normal saline to make sure that that line is patent, because in most of them you want to run some fluid. So this running of fluid too is another problem. That's where sometimes, even though the patient is not overloaded, we run a lot of fluid through the line, and then now the child gets overloaded. As to whether to continue the transfusion, you need to it's I think the one that in the febrile non-hemolytic transfusion reaction, where it's just the fever, you give antipyretic, you make sure that there's no hemolysis going on. That's the one that you can continue the transfusion. But best scenario, stop the transfusion, flush the line with normal saline, and call somebody senior so that you can discuss it and then take a decision. If it's febrile non-hemolytic transfusion, a decision can be taken to continue the transfusion. But in the others, like the transfusion related acute lung injury, or the hemolytic one where the urine has become dark, baby is bleeding, or the anaphylactic one, you want to stop the transfusion and take that, fill the transfusion reaction form, take that sample, the blood, back to the blood bank for them to recheck on the blood, check the ABO, check if the other antibodies. So most times we would stop the transfusion if we notice a transfusion reaction and then investigate. It's only in the febrile non-hemolytic that you may want to continue, even that you stop for a while to be sure that that's the only problem and there's nothing else that is involved before you consider continuing that transfusion. So most times it's best to stop and then investigate why the transfusion occurred. Thank you.
Thank you. Ethel Ninara, your hand is up. I don't know if you can unmute yourself and ask your question. You are allowed.
Thank you very much. Doc, thank you for your presentation. So please, I have 3 questions. I don't know if I should take all at once or I should go one after the other. Like after you answer one,
Okay, you ask all 3, I'm writing.
then I move to the next one.
You mention all 3 because maybe some of them may be related. So you go on.
Okay.
Ask the 3.
So please, in my facility setting, we don't usually have the other blood products. What is always readily available is whole blood. So I'm realizing that we tend to use whole blood for almost virtually everything, because they always say that if you want plasma, whole blood has a plasma component. If you want red blood cells, like that kind of thing. So because getting those other blood products is usually very challenging. Even the whole blood sometimes is a tug of war. So it's like we always have whole blood available. So I wanted to find out if maybe we need just fresh frozen plasma, but at the moment we don't have, and it's an emergency. So where we need to give whole blood, are there some special precautions that need to be taken? That's the first question. Then the second one is, you mentioned for the febrile, I think the reactions. You mentioned that when there's when the temperature rises, we can give some antipyretics. I wanted to know which antipyretic will be best for the neonates. Then the last question is the best fluids to run after a blood transfusion, or maybe there was a thank you.
Okay. So let's start with your middle question. Which antipyretic to give? Paracetamol is safe in babies, so you can give paracetamol. Okay. 10 milligram per kg is fine to give if that is what is happening. There's a rise in the temperature. Paracetamol is safe. About the blood product, yes, it is a challenge everywhere. It's not like in the teaching hospitals or regional hospitals is any better. Blood is always short because we have this culture where we don't voluntarily donate blood. And so blood is always short everywhere. So most of the time, the blood bank is relying on replacement, family replacement. So there's never enough of blood. The other challenge which you talked about is like at the lower facilities and most facilities is the whole blood that is available. They don't have, I guess, the capacity to do the separation into the various components. And then you asked a question about using FFPs. Let's say you need FFPs, and because you don't have FFPs, you use whole blood. Are there any precautions to give? So even though whole blood contains everything, it has a shelf life, and you know the FFPs is prepared from fresh blood and frozen. So it has a lot of clotting factors, which are still, once you thaw it, it does what it's supposed to do. But when you have whole blood stored, it doesn't maintain all the clotting factors in the proportions that you require for the indication that you need. So if you are requiring FFPs, I'm thinking that maybe the person is bleeding or, yeah, usually that. Giving the whole blood may do something, but it may not achieve as much as if you had FFPs to give. Because the whole blood, majority of it is actually, you have more red cells in it, and depending on how old that blood is or how old that blood has been stored, you may not have enough of clotting factors in it to achieve the purpose that you are given. So I don't know, but in places where they don't have, the zip line works as well. So when I was in Coco, actually now this morning I called the lab person at Holy Family Hospital in Nkoko, and the zip line still works. So if we need FFPs or we need packed cells, we put in the request and then it comes. What is difficult sometimes is when you need platelets, because platelets has a very short shelf life, 5 to 7 days. So something you call and then you don't get, or the cryo you don't get. But at least packed cells, FFPs, it's available if you request it through the zip line. So you can consider that. You can have a discussion with your blood bank manager to see, because locally most are not able to process the blood into the various components. The other thing too is that you see, if we are using whole blood, kind of seem like a waste of resource, when from that whole blood we can prepare so many products from it for for different purposes. So ideally we should be pushing more to get these blood products separated into the various components so that we can, from one donor, we can use it for different purposes rather than just using one donor, one whole blood, one patient. It's a form of waste when we don't have enough blood. Don't know. Have I answered all your questions?
Yes, Dr. Ansedi.
Yes.
I think for now, we hold on with the questions. If you have any question, kindly put in the chat box. Dr. Ansedi is still around. Kindly hang out we move on to our second speaker. Thank you very much, Dr. Seidu, for
You are
this
most
insightful
welcome.
presentation. So we'll move on to our second presentation for the day, and it will be taken by Antoinette Asari Akuwa. She is a neonatal nurse specialist and in charge of the NICU of Valley View University Hospital. She has practiced 7 years as a midwife and 3 years as a specialist in the neonatal nursing. Please join me in welcoming Antoinette Akuwa. Antoinette, you are welcome.
Hello.
Hello, Annette, we are ready for you.
Okay, can you please hear me?
Yes, but your slides are not showing.
Okay. Let me try and share it. Can you please see my screen? Hello.
Hello, Annette. No,
Yeah, can you please see?
no.
I'm finding it difficult to share. I don't know if the IT can help me.
All right, okay. Okay,
Can you see it now? Please, can you see my screen now? Hello.
yeah, Annette, are you sharing with your phone?
Yeah. Please, can you see it now?
So let me forward it to the IT department for them to share it for you, okay?
Okay.
You can log up. Please, Dr. Ansedu, if you're around, you can answer some of the questions in the chat box for us as we prepare to project the second. Okay.
Okay. Okay. I'm doing that. Or you want me to talk or?
Please, there are some questions in the chat boxes. The chat box.
Okay, so I should answer them.
Yes,
Okay.
please.
So there was a
I don't-
question about please in transfusion reaction, can we continue the transfusion in some of the if some of the reactions, example the febrile ones. Like I said, ideally you should stop the transfusion and fill an adverse reaction form and take the blood back to the blood bank. because even in the febrile ones, the ones that it's just a rise in the fever level from the baseline, you need to we need to investigate and find out, is a blood sample contaminated with any bacteria? Is there any sepsis ongoing? Is there hemolysis ongoing? So that takes some time. So you need to pause and find out what is going on before we consider restarting that transfusion. So always, if there's a transfusion reaction, please stop, fill a transfusion reaction investigation form, take the blood back to the blood bank, and let some investigation go on before we consider retransfusing that blood or finding another blood product to give the patient. There's also a question of what should one do if a baby is having pyrexia during transfusion, although baby is at risk for rising temperature due to his condition. So meaning that the baby is already febrile, and then we start the transfusion and we notice that he has a fever. So that's a tricky one. So I guess it comes back to the monitoring. So you know where you're starting from. So if there's a rise, then yeah, it's difficult to tell whether it is his condition that is making his temperature rise, or it is the transfusion that is causing that transfusion, that fever. Is it a transfusion reaction? So that's difficult. I would suggest that again you pause and then we re-examine the blood and see if that rise in the fever is just is due to the blood or not. And then so I think that one has to be discussed case by case, because having a rise in the fever could be because the baby already has his underlying problem, or it could be the transfusion reaction. So it has to be discussed, then we take a decision. So everything is not straightforward like that. But if you started off with nothing and now you're having the fever, then that fever, you'd have to attribute it to the blood that you are given, and so stop the transfusion. Somebody is also asking, is there a need to give medication before transfusion to prevent reaction, or should be given only during cases of transfusion reaction? So most times, if you've done your processes right, blood bank has done the grouping and cross-matching well, you selected your appropriate products to give, most times you don't need pre-transfusion medication. A few cases where babies have required multiple transfusions and they've had an adverse reaction before, then in your next transfusion, we may consider giving some pre-medication. But if not, most transfusions actually don't require pre-transfusion if you selected your products appropriately. Okay, now I see the presentation up. So should I go on or I should stop?
Thank you so much, Dr. Anseidu. I think we will continue on as we go ahead. For now, please continue to hang in there for us. In case of anything, we will get back to you. Thank you very much.
Okay, thank you very much. I'm very sorry for the delay. Kisa, I want to thank you very much for giving me this big platform this afternoon. I really appreciate it, and I thank you very much. My name is Antoinette Asare. Now, Kowa is my nurses, but when we come to work, I'm Antoinette Asare, a neonatal nurse specialist from Valley View Hospital, Echiman. As we recently voted and did our elections, we know very soon Nana Addo will be handing over. Nana Addo will be handing over very soon to Mahama. So in life, we do handing over each and every day. So today we are coming to our field as clinicians to talk about handing over, especially in NICU. So that's our outline given. And our objective is that by the end of this presentation, please can you go back to the objectives? We will know the definition of handing over, the purpose for handing over, benefits, and types of handing over. And we'll also talk about the hindrances to effective handing over. If you want handing over to go on smoothly, there are certain things that prevents us. And we have a communication tool that usually can be used for handing over, and that's the ISBAR. Some people will say ISBAR. Some people also add O to it to be ISOBAR. But today we will use the ISBAR or ISBAR. So as I said, handing over is an important part of our job as clinicians. Handing over starts from taking up. If handing over will go on smoothly, it will start from how we take up from the other staff. Handing over can be done between nurses, two nurses, can be done between a nurse and a doctor, or can be done between doctors, can also be done when referring a baby to another facility or another unit. Basically, we are talking about NICU, so you will see me using babies instead of patients. So we will use babies. And it's very necessary to have an effective and accurate, methodical and consistent handing over before and after every shift, whenever a baby moves from another team, as I said. So let's talk about the definition. How do we define handover? And handover is a process where a specific information is shared between clinicians who are responsible for taking care of babies. And since we do family-centered care, we do not leave the families aside. We involve them also in our handing over. So what are the purpose or the reason why we should hand over? Why should we hand over? It allows clinicians to share information about the baby's care and treatment. If you do not share, how do you continue the job? How do you continue in taking care of this baby? So it also improves the continuity of care and also a better outcomes for our babies. If I'm supposed to give a medication at 10, I give, and I don't document and hand over, how do you give the next dose? We have to hand over so that we continue the treatment so that it will help the baby. It reduces work burden for staff. If, let's say, the ward is too packed, the best thing we can do is to share the babies among ourselves so that I'll concentrate on a few and know what I have done and document what I've done, know everything about the babies I'm taking care of, so that when I'm leaving the ward and someone is taking up, I would be able to process everything that I have done and pass on to the other party to continue. And when it happens like that, the workload is reduced, then I know what I'm supposed to hand over, and it will go on smoothly for us. We will move on to the benefits. The benefits of handing over. It reduces avoidable harm. It reduces baby's history reputation, baby's history reputation. It's also a better support for doctors' clinical decision making. If you know the history of this baby, you know everything about this baby, and you call a doctor, the doctor will know what to do and know how to continue from where he has stopped. It also reassures for relatives with the latest relevant information. Reassures for relatives. Sometimes we leave the relative aside. You meet a mother, you ask, what is wrong with your baby? I don't know. They said I should take this baby here. I should take the baby to the lab. You don't know even the reason why you are taking the baby to. We don't inform them about anything. We leave them out. So you must also tell them or inform them about the things we are doing for the baby. And handing over also reduces stress, as I said. It reduces time reviewing baby's record. Everything that we do should be documented. We are not going to base much on documentation. But if you want to hand over well, you must document everything that you do. So if it's documented and you are handing over, it reduces time and reviewing the baby will go on smoothly. It maintains consistent, accurate records and audit trials. If there's in case of any death or anything and we need records, we need anything, a document to find out whether what you did for the baby is documented. You will come back to your documentation or your handing over note to see whether truly you did what you were supposed to have done. Please, can we move on? We want to move on to the types of handing over. The types of handing over. We have the oral handing over report and a written handing over report. Please, let's move on to the oral handing over report. The oral handing over report basically talks about the ones that are not mostly permanent. Or you call a doctor on the phone, sometimes you call a colleague on the phone to give a report. That one is an oral handing over. You call a referral center to give an information. It's an oral handing over report. And it may include some of the written reports. The written reports can also be given verbally. The handing over first should be done at the nurse's station to avoid giving out some vital information by the bedside. So you first do it at the nurse's station among yourself before you go to the bedside to also hand over. And a written handing over report also is a report that are given when the information to be used by several people or more less of permanent values. Now we are moving high and we are going IT. So everything mostly on computer, the links or documented on our records, treatment sheets and other things that is supposed to be permanent for referral sake, for reference sake rather. So that will be the written part of it. As I said, there is a tool that easily helps us in referrals, in handing over, even among doctors, among nurses, that helps us to do a smooth handing over. And the first thing I'll talk about is the I, which is identity. The identity. You specify who you are. In case it's on phone, an oral report, if it's an oral report, you mention your name, where you are calling from, who you are, where you are working, before you go to the patient which you are dealing with or the baby you are dealing with. And if it's not on phone and it's between nurses, they know your name, you know Annette, I know Barakisu. So we just move on to the baby. Move on to the baby. I'll give an example. I don't want to give the example now. So when I finish, I'll give an example of the ISBA handing over. So you mentioned the baby's name, the port number, the age, the gender. Then you move on to what is the problem. What is the problem with the baby, the situation, which is S? Currently, what is happening to the baby? Maybe if it's an oral report, you say, I'm calling because of this condition, this or that. Or I have observed some major changes in the airway, the breathing, the circulation, whether baby is dehydrated or anything. The observations you've done for this baby, the vital signs you have taken for this baby. You don't have to call someone without knowing what you are supposed to do. I learned this when I was doing my service in Kintampo. There is this doctor. If you are calling him and you don't know anything about the client, forget. You must know everything from A to Z. Past history, medical history, surgical history, the current, everything. So you don't just call the doctor and the doctor will ask you, okay, you said baby is in distress. What is the ABGA score? You don't know. Baby is in distress. What's the SQ2? I have not checked. Then what are you talking about? You have to know all these values. You have to know all the vital signs and everything before you call or before you hand over this baby. You must do all your checks and balance everything before. Then you move on to the background. The background is the history behind this baby. Whether the past history, where was the baby from? Was the baby from the house? Was the baby referred from the line in? Was the baby brought from another facility to your facility? The background of the mother, how the delivery went, and what is happening to the baby, what led to the baby's admission. And you give the admission date, the diagnosis. If the baby is having a previous illness, you give any relevant problems or treatments, intervention. To date, you also give it. If the baby is having any allergies, that will be given at the background. And after all these background checks, situation and everything, you assess what is the problem. So after all this, what is wrong with the baby? All this that you have done and why you are calling. What are we supposed to do for this baby? I think the problem is this. I think the problem is this. The baby is having this problem. So I think this is what we are supposed to do. I don't know what the person is, but the patient's condition has deteriorated. The baby's condition is deteriorating. So what are we supposed to do for the baby? Then after the assessment, you suggest. You don't conclude for the person, let's do this, let's do that. But you suggest, I suggest we refer this baby. Or I suggest we change the dose or we change the medication. We have first line medication, second line. So if the first line medication is not helping, I suggest we move to the second line. Or we can also, if we are level 2, like where I am now, and you are referring a baby, you must indicate, maybe I'm referring this baby for further management because of this or that. And that is the recommendation, the last one. That's the recommendation. I suggest we do this or we take this immediate intervention and other things. That would be for the recommendation. As I said, I'll give a small example of handing over that I wrote down. It's not in the slides, rather, but I'll give a short one. Maybe you have a baby in pot 1. So a 5-day-old female baby called baby Abena Asari. That will be for the I. That is the identity of the baby. Then you move on to the situation. Maybe baby is diagnosed of jaundice or this condition. Baby's serum bilirubin level is this. And currently the baby is under photo. You have checked the vital signs, temperature, 36.9, pulse, respiration, everything, SpO2, this and that, capillary fill time, less than 3 seconds, and everything. So currently baby is under photo. receiving treatment. What was the background? This baby was delivered via CS 5 days ago. That was on the 9th of December. But 2 days, baby had not had breast milk for 2 days. And mother is also a G6PD partial defect. So if this baby is jaundice, there is a cause for alarm. The baby is seeing yellowish on the 3rd day, so was referred to NICU. Since mother is G6PD partial defect, baby should be monitored very well to get the serum bilirubin level and know whether it is deteriorating or it is increasing, or so that you know what to do next, whether to change the phototherapy machine. For us here, we only have the phototherapy, the Firefly and other things we don't have here. So if you are supposed to refer for further management, you refer. So I suggest maybe if the jaundice is increasing, you report to your other staff that I suggest it is not working, so let's refer. Or doc, please, I think the baby is improving. Doc, please, I think we should refer. Or please, Kisu, please take care of this baby for me. So after all these things, you can use during referrals, you can use between staffs, 2 staffs, and you can also use from a nurse to a doctor. This is what mostly happens that hinders our effective handing over. If our handing over will not go on smoothly, these are some of the things that I've stated that will hinder us from having a smooth or effective handing over. Lateness to work. Lateness to work. You are to report for afternoon shifts and you'll be coming around 3 p.m. Someone has come in the morning as early as 7:30, and you will come for afternoon shifts around 3:30. You are in a rush. I've stayed for a very long time. So what do? I have to rush through the handing over. Also, baby, what they are to us. My late. My car is in. I have to go. I've not even eaten, and you are late to work. But if you come earlier, we can have time and go through all the handing over and everything. Before you can go home. I can go home and you can continue the work. Another point is our poor history taking and assessment. As I said, if you are handing over, you must know everything about this baby from head to toe. You must have done your assessment, know the history behind the baby's admission, what the baby is currently on, what are you doing next, and everything. You must know everything about this baby before you hand over. And there must be nothing left out. In case something is left out, it will not be something that cannot be done. That cannot be done. So it will be something that you can easily do for the baby. Please, I think the slide has stopped, so I want to continue from mine. And one is also lack of concentration during the process. Lack of concentration during the process. I'll be handing over and you'll be talking somewhere, looking on your phone, watching a video. Okay, I'm listening. You continue, I'm listening. But be doing something else. You will finish and you will forget what the person said or what the person told you, and you wouldn't know what to do for this baby. But if you have a concentrated mind, you listen to everything that the person is saying, you will be able to continue the work smoothly. Poor interpersonal relationship among staff can also hinder effective handing over. If Barikisu is fighting with me and I get to the ward, I will just move in, sit down, okay, I'm here, you can go home. But these things shouldn't affect our work. If you have an issue with the staff, it shouldn't affect the work that you are doing. It shouldn't affect the babies in the ward. Come to work, do your work, do everything. When you go home, you can continue your fight. You can continue your argument. But when you get to work, it's time for business. It's time for work. So put everything aside, all emotions aside. Then let's work as one body to help our babies. Poor documentation. Poor documentation. Hello.
Hi,
Please, can you hear me?
I can hear you.
Oh, okay. I thought maybe I'm off. Okay. So poor documentation. If we do the work and we do not document, if I have given this medication, it's not documented, I don't chart the medication I gave. As we just did, you gave a transfusion and you didn't document. How do I know when the blood stopped? To know when to stop? Hello? 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 Please, can you hear me? Hello?
Barkisu, we can hear your background. Annette, we can hear you. I think
Oh,
Barkisu can't hear us.
okay. So we have a proper documentation or we take record of everything that is going on our period of work and everything documented. When handing over, it will go on smoothly without any hindrances. And I'll move on to something very important that mostly we forget during handing overs. Handing over of equipment and consumables. We have wear and tear, so mostly our equipment gets. You don't have to be blamed for spoiling any machine or any equipment. So if something spoils in the ward and you are there, avail yourself, report it, document it that this thing is false. Hand over those machines. This incubator is not working. This phototherapy machine is not working. Oxygen is finished. You must hand over all these things. If the fan is not working, the light is not working, things are the worst, everything should be handed over. If you don't hand over and I get an emergency, I want to use this, I have to administer oxygen. And the oxygen is finished, you didn't hand over. What do I do? It becomes stressed out. If I know I have the proud notice that oxygen is finished, this machine is not working, I know what to do when I get an emergency.
Hello, dog.
Cotton is finished, there is no cotton, there is no plaster, there is nothing, this and that. All these things should also be during handing over. Medications in the fridge. The scenario that was given on one of our platforms, I really liked it. There are some medications in the fridge. This in charge malt is here, all those things. Everything should be handed over before you go home. So handing over should not be in a rush. You should take your time, know everything, document everything so that it will go on smoothly for us. So in conclusion, what I will say is that work that starts with inadequate knowledge makes the following hours ineffective, stressful, and potentially dangerous for our babies. A rush or incomplete handover delays babies' care discharge, and it increases the number of preventable medical errors. Thank you very much. Thank you very much. My reference is there, but I think they don't have it. So, Kiso, I will send it to you. So thank you very much.
Thank you very much, Antoinette. I'm so sorry for the technical issue we had earlier.
Oh, okay, don't worry.
Please, the forum is open. The floor is open for any questions, suggestion, addition, or any recommendations. Please, if you want to ask any question, you can raise your hand and the host will unmute you so that you can ask your question. Thank you.
So I have a question for the house. I didn't talk about myths and misconceptions. So if you have any, you can bring it forward. Thank you.
Oh, hello. Antoinette, thank you very much for your talk. Unfortunately, I didn't join kind of earlier. My name is Dr. Jean Japon. I'm a neonatal consultant in the UK, right? And I find these your meetings very interesting. So just for Antoinette, I don't know whether I like the way you talked about kind of the different types of handovers. And you stressed about clinicians, and you seem to include both nurses and the doctors. So do you, on your unit as well, I know you seem to have gone into more of handing over between sort of a doctor and a nurse, or a nurse and a nurse, or when babies are being transferred. What about within the unit itself? Because the kind of practice that I am kind of used to, and I thought that is really, really helpful, is normally the nurses come before the doctors. So let's say for us, for example, the nurses come in at about 7:30, or sorry, 7 o'clock. Then they do their big handover, and there is normally an in charge who has a printout of everything that happened, let's say during the night. So there's a kind of handover for the whole nursing team. And then the in charge who was there overnight will hand over specific babies, to the in charge as well. In the meantime, the other nurses will then go to the ward, and whoever is allocated, which baby. So if I'm going to look after baby A and B, or A or something like that, the nurse who looked after the baby overnight will then hand over to me, right? So what then happens later is when the doctors also come in for their handover, right? So normally there will be, let's say, an SHO or resident or whatever who was on the night, knows whatever happened. They also have a sheet which they update. And then they will the nurse in charge who has had a handover from the nurse in charge, during the night will actually join the doctors, right? And then, sort of give a brief handover, with some of the babies or what happened overnight. And interestingly, there are other things that we do during that time. So we have something we call briefing, for example. Okay. So this briefing means you talk about the whole unit, what is going to happen, let's say for the day. So there is maybe a cesarean section for a 28-week mom who has severe PET or something like that, and it is planned for 11 o'clock, let's say. We've received a call from St. Jude Hospital, for a baby who is sick with this, that, who is going to come to us and is on the way, that kind of thing. Or we have this baby C who is supposed to go for an MRI today, or who is going for laparotomy because we suspect neck. So basically talking about the whole activity, and not just the babies who are there, because there may be other activities or something that may be happening that may impact the kind of workload or things that happen during the day. So these are some, I can go on and on and on about some of the aspects of kind of handover that we kind of do. So that's my just my little kind of contribution to this. But thank you very much.
Thank you
Thank
very
you.
much, Doc. A hand is raised. Someone raised. And kindly unmute your speak. Yeah, unmute yourself and speak. Okay. Dr. Saidu.
Yes.
If there's a question, someone is asking, when transfusing blood, it needs to be covered with a cloth to keep other patients from seeing the blood. Is this backed by evidence?
Okay, thanks for the question. I mean, blood is it's a therapy we are giving. I'm not sure we cover our IV fluids when we are transfusing. There are some medications that need to protect from sunlight. Blood is not one. So if we are covering it, it's more for cultural or yeah, there's no reason to cover the blood scientifically. Like it's more for social cultural or psychological purposes. That's why I think some would cover the blood so that, well, other patients don't see they are being transfused with blood, but there's no scientific reason to say that if you cover the blood, then this will happen, or if you do, then this will happen. There's nothing like that. So I think it's more of psychological, cultural reasons. Yeah.
All right, thank you. Dr. Saidu, some of the myths about transfusion is all about adults. Akwala de onji moja. If say you transfuse a baby, there's a question mark on the baby. Akwala de oba we said that ben na obeji moja. So they tag those babies. So that's some myth about blood transfusion.
I think a lot of people's perception about babies is that baby is born, baby is healthy, baby is fine. But we know babies have a lot of, well, not every baby, thankfully not the majority, but at least 1% or 2 would have some problem for which they have to be admitted and be in NICU. And it's for those who end up there, they are the ones who see that their babies can be sick. So in the general public, the notion out there is you have your baby, you go home, you do outdooring, everybody's happy. But it's just a few who get admitted, who get to see the other side of the neonatal period. So I think that's why such perceptions exist in the community, that why blood transfusion for a neonate.
Thank you.
So there's one I thought was a myth, and then
As we are closing the year,
all right. Okay, I wanted to say one more thing. So
okay.
I think sometimes we say that if you are transfusing, you shouldn't feed, right? Is that something that we do? Barricades? If you are transfusing, you feed the person.
Yeah, we feed them.
Okay.
And
So-
when they are due for medications too, we give it to them via a different line.
Okay, so I came across the thing about transfusion-associated necrotizing enterocolitis. And so there's a bit of caution to do there, especially for babies who are small, less than 1,005, very sick. If you're considering transfusion, it's best to omit feeds during the transfusion, just so as to reduce the risk of having necrotizing enterocolitis for such babies. So in that group of patient, less than 1,005, and then ill babies, you should omit feeds if you are transfusing. Thank you.
Wow, thank you very much. Dr. Adoma, please, are you around? Do you have any end of year message for us?
Yes, Barikisу, thank you. Thank you so much for organizing this meeting. And thank you, Genevieve and Antoinette. This was a very, very interesting set of presentations that you have given to all of us. And I know it's going to go a long way to help us as we end one year and as we enter into the new year. And I know that even as the politicians do their handing over, we will remember the message that Antoinette gave us in starting, that we also need to pay particular attention to our handovers. So I'd like to say Merry Christmas to you all, Happy New Year to you all, and may we make as part of our new resolutions an effort to save more and more newborn lives. So thank you all, and God richly bless you.
Amen. Dr. Adoma has infused the vote of thanks in her message. We are almost at the rush hour. Some of us would like to go and pick our kids from schools and other things. Evelyn, can you please give us the vote of thanks and the closing prayer?
Okay, thank you. I was thinking Dr. Duma has done my part for me. All right. So we thank the facilitators for this insightful presentation that they have given us. We've learned so much, and we pray that we add it to our work. I want to thank Dr. Nisiedo and Mrs. Akowa for their presentation. We want to thank our IT team for helping us have this successful session. And we want to thank the organizers of the Perinatal Conference as well. God richly bless you. We are also thanking everyone who has taken their time to join us with their data. May God richly bless you all. We pray that this year when we call, we will all join in our numbers. Let's pray. Oh Lord, we thank you for a successful session. We ask that your grace will be sufficient for us to learn new things, that we will put it into greater use. In Jesus' name we pray with thanksgiving. Amen.
Amen. Thank you all once again for joining us today for this informative webinar. We hope you found this discussion helpful. Don't forget to join us in the next year, 2025. We shall meet. Bye-bye.